Welcome. My name is Tabitha Dromiak, and I will be presenting education on hypertensive disorders in pregnancy and recognizing their signs and symptoms. This presentation will cover the knowledge, skills, and attitudes related to the care and treatment of women with hypertensive disorders of pregnancy. In order to recognize and understand the signs and symptoms of hypertension, we must first know the types of disorders and their effect on women and their fetuses. Let's gain some knowledge. Before we look at the four primary types of hypertension, let's learn about the primary diagnostic criteria for all hypertension. That is, blood pressures greater than or equal to 140/90 on two occasions at least 4 hours apart, with either or both systolic and diastolic levels exceeding the threshold for diagnosis. Chronic hypertension is hypertension diagnosed or present prior to the 20th week of gestation. Keep in mind that 20 to 50% of women with chronic hypertension will develop superimposed preeclampsia. Gestational hypertension occurs after 20 weeks gestation and does not present with additional symptoms such as proteinuria or end organ damage. The most dangerous hypertensive disorder is preeclampsia. Preeclampsia is categorized as with or without severe features. Pre-E without severe features uses the same threshold for hypertension and includes proteinuria or another symptom of preeclampsia, while preeclampsia with severe features requires two blood pressures greater than or equal to 160/110 at least 4 hours apart, or visual disturbance. Either of these in conjunction with proteinuria and or additional pre-E symptoms such as a platelet count less than 100, signs of end organ damage as evidenced by lab work, oliguria or specific pain, pulmonary edema, and new onset headache that won't resolve with treatment are all diagnostic. The fourth disorder is preeclampsia superimposed over chronic hypertension. It's particularly important not to dismiss signs and symptoms of preeclampsia by blaming elevated pressures on pre-existing chronic hypertension. Be on the lookout for increases in pressures in patients who were previously well controlled by medication, a new onset of proteinuria, or an increase in the baseline of the patient with known proteinuria in early pregnancy, as well as all other symptoms associated with pre-E. Hypertension is the most common medical disorder occurring during pregnancy, complicating up to 10% of pregnancies. It is also the leading cause of maternal mortality in industrialized countries. Maternal complications include increased incidence of placental abruption, postpartum hemorrhage, pulmonary edema, end organ damage, seizures, and death. It's important to note that there are significant racial disparities in the prevalence, diagnosis, and treatment of hypertension and preeclampsia, with the highest burden experienced by non-Hispanic Black women. Fetal consequences include increased prevalence of meconium aspiration at delivery, intrauterine growth restriction, low birth weight, preterm delivery, mostly from planned deliveries between 34 and 37 weeks, negative sequelae of placental abruption and maternal seizures, as well as fetal death. Risk factors include nulliparity, advanced maternal age, particularly over 40, gestational diabetes, obesity, maternal or family history of chronic hypertension, prior hypertensive disorder of pregnancy, kidney disease, stress during pregnancy, lower socioeconomic status, inadequate late or no prenatal care, and smoking. The most obvious symptom of hypertension is high blood pressure readings. Normal blood pressure in pregnancy is between 90/60 and 120/80. Providers should be closely monitoring patients whose blood pressures start increasing above the normal range for signs and symptoms of preeclampsia. Another sign of preeclampsia is proteinuria, which is protein in the urine. Pre-E can be diagnosed either with the 24-hour urine test with a value equal to or greater than 300, or a protein creatinine ratio performed on a small amount of urine with a result of 0.3. PC ratio results are more immediate and as reliable as the 24-hour urine, so are performed more regularly. The following symptoms are what I refer to as the Big Five. These are the most common symptoms a patient may experience on the onset of preeclampsia. They are a headache that does not go away with treatment. This is a sign of increasing intracranial pressure that could result in a brain hemorrhage. Visual changes, including blurring of vision, floaters, sparkles, and spots. This is also a sign of increased intracranial pressure. Epigastric pain, primarily on the right side under the breast. This is a sign of increasing vascular pressure in the liver that could lead to hepatic rupture. Nausea and vomiting can indicate a buildup of toxins that are not being cleared by the kidneys, which triggers these GI symptoms. And swelling, also called edema, primarily in the feet and hands, but also the face and body, is an indication of third spacing caused by intravascular pressure. Fluids leaving the circulatory system take electrolytes with them, and this can result in a dangerous electrolyte imbalance. Additional information on patient status comes from their labs. While there are only 5 lab values that are considered diagnostic of preeclampsia, there are many labs that we must look at that will support the diagnosis or indicate that trouble is brewing for your patient. Diagnostic labs are, as previously mentioned, the 24-hour urine or the protein creatinine ratio, as well as liver function tests, ALT and AST, being 2 times their normal value, and platelets less than 100. While not diagnostic, changes in the following labs should be on your radar when considering the patient's history and current clinical presentation. These labs include calcium, magnesium, potassium, and sodium. Changes in these can indicate potential third spacing, so definitely watch your patient for edema. Abnormal hematocrit, partial thromboblastin time, and fibrinogen are signs of hematological changes related to clotting in individuals who may be developing pre-E. Abnormal lactate dehydrogenase and alkaline phosphatase signal end organ damage to the liver, and increased creatinine and uric acid signal damage to the kidneys. All patients, even those who do not appear to be at risk, deserve a full initial assessment that includes questions and physical assessment techniques that would reveal potential signs and symptoms of developing or worsening pre-E. Do not be fooled into thinking that your patient doesn't need DTRs or thorough lung auscultation just because they appear healthy. The following slides will discuss the skills you need to practice and hone to properly assess and care for patients with any hypertensive disorder, particularly preeclampsia. Practicing your assessment, procedural, and educational skills will increase the quality of care you provide, as well as patient safety. Performing a thorough physical assessment on your patient is a must. Include these items in your assessment. Assessments that we haven't previously discussed include taking a full set of vital signs, including the often overlooked respiratory rate. Increased respiratory rate can be a sign of fluid on your patient's lungs. Auscultate those breath sounds. Ask about shortness of breath and any difficulty breathing. Listen for diminished or adventitious breath sounds, particularly in the lower lung fields. Assess DTRs. These may be hyperactive in the presence of hypertension, indicating your patient's increased threshold for seizure. Assess for clonus, which is also an indicator of increased seizure threshold. Proper technique is vital. Use the following tips and procedures to take the most accurate blood pressure. Prior to taking blood pressure, verify that the patient has not consumed caffeine, smoked, or participated in strenuous activity within 30 minutes of the blood pressure reading. Also, have the patient empty their bladder. The patient should be reclined semi-Fowlers with their back supported in bed for at least 5 minutes, legs uncrossed and arms supported at the heart level. Place a properly sized cuff on the patient's bare upper arm, not over clothing, and remind your patient not to talk during the measurement. And one of your most important skills, patient educator. Your knowledge of this topic will allow you to properly educate your patient on prevention, mitigation, or reportable symptoms of hypertension. Share this information with your patient. Recommend that they see their provider early in pregnancy to establish a baseline blood pressure and detect any early signs and symptoms. Follow their provider's recommendations for weight gain, physical activity, and diet. Drink adequate water, avoid stress. When they rest in bed, tell them to lie on their left side to maximize blood flow to the fetus. Know the big five. Don't ignore symptoms and have them contact their provider if they have any new or worsening symptoms. You should also teach proper blood pressure taking technique and recommend taking blood pressures at home per their provider recommendation. And finally, values. Understanding hypertensive disorders of pregnancy and having the knowledge to recognize them, as well as honing the skills needed to properly assess and treat them, is just one of your superpowers. By learning and internalizing this information and bringing it to your daily practice, you will be a literal superhero to your patients. While chronic and gestational hypertension are often identified during a woman's prenatal appointments, you will find women arriving on your labor unit with symptoms of preeclampsia, or you may see the disease present for the first time while they're in labor. Your attitudes and values related to the care and treatment of your patients, your desire for knowledge, your commitment to furthering learning and understanding, your acknowledgement of the effect of race in hypertensive disorder diagnosis and treatment will all help you recognize the symptoms as they present, allow you to put together a picture of your patient's condition or a potential condition, and drive you to bring the findings to the care team with the proper recommendations for management and treatment of your patient. Thank you for joining me for this presentation. I hope you're leaving with a greater understanding of hypertensive disorders of pregnancy, the knowledge to recognize the signs and symptoms, the skills to assess for them, and a sense that your attitudes and values play a huge role in providing the proper treatment for the women in your care.